We generally recommend that nerve transfers are done, you know, somewhere really, in my book, from sort of 6 months to 12 months, but maybe as much as 18 months. If it's a nice short distance, a nerve transfer has to travel after a spinal cord injury. And there's not very much in the literature, but some late nerve transfers have been undertaken with success. And age and time post-injury has been suggested as contributing to outcomes. So our aim was to assess power outcomes in patients who'd undergone delayed, more than 18 months post-injury, nerve transfer surgery. And it was a retrospective database review, and we looked at all our tetraplegics who'd had late nerve transfers, where we had an MRC grade of the recipient nerve's muscle measured at least 12 months post-surgery. Now, I just want to stress that only patients whose recipient nerve's muscles were able to be stimulated using surface electrical stimulation were selected for nerve transfer surgery. That is our sort of base, you know, that's the make or break. If you don't stimulate and you're late, you're not getting a nerve transfer from us. So we looked at the patient demographics, the age, the gender, the limbs, the clinical demographics, the level of injury, the time to surgery, time to follow-up, the surgery performed. All of our patients have preoperative EMG, and we're looking for fibrillations and fasciculations in the donor and recipient muscles, and then recruitment also in donor and recipient muscles. And intraoperatively, we recorded information about the intraoperative nerve stimulation, and we're looking at the stimulation threshold and then the range of movement in the muscle when you stimulate the recipient's or the donor nerve. And then the Medical Research Council, our very crude measure of power. So here is someone being stimulated pre-surgery to determine whether they've got finger flexion and thumb flexion. So they are someone who might qualify for a transfer into grasp and pinch in a delayed way. And this is a patient who's also has some ability to have the wrist extension stimulated and a little bit of EDC as well. So intraoperatively, there we are sort of set up to do a ECRB to AIN and a pronator teres to FDS transfer. In the end, we had looked at 21 nerve transfers in 15 patients. Mean, very standard looking demographics there. Mean age was 31, 5 females, 10 males. Mean motor level pre-surgery was C6, international classification 2, but between 1 and 5. Mean time to surgery was 74 months, but as much as 300 months, which I think is like 25 years or something, and follow-up range, which was 12 to 93. So we did 3 nerve transfers for elbow extension. We did 1 for wrist extension. We did 6 for grasp and pinch, including 4 who had a brachioradialis to ECRB as a tendon transfer as well, and then a supinator into AIN. Now these patients are not patients that you can where we've done grasp and pinch in a late patient, it's where we can't do a tendon transfer. Okay, so these are patients who they don't have donors to have a tendon transfer. So if you can put a nerve in late, you can potentially give them grasp and pinch where there was no option to do that previously. And 11 supinator to pins. So now because we've got such tiny numbers, this is almost a bit silly, but I've just presented you, these are our median, so triceps 2, which triceps 2 is not a bad thing to have for a patient. You know, if you've got a peripheral nerve injury, a MRC grade of 2 is no good most of the time, but for the spinal patient, being able to go across gravity greatly increases your ability to your working space. And then you can also sort of trick the arm up into above above your head. So MRC3 for wrist, which is just enough to get your wrist up, hand opening 4, grasp 4, and pinch. You can see not very good, a median of 1, and that's probably because FPL is often denervated. Because, you know, as I say, such small numbers, this is what it actually looks like. So elbow extension, we had 1 which was an MRC of 1, 1 which was an MRC of 2, and 1 which was an MRC of 4. Wrist extension, we had 1, 3. Hand opening, we had mostly 3s and 4s, so 6 patients and 3 patients respectively. And then grasp, we had some fails really, a couple of 1s, but then also some 4s. And pinch, not looking as good. So when you look at the failed nerve transfers, we've got a range of ages there, 20, 19, 32. We've got a range of time to surgery, 32 months, 52 months, 84. We've got a range of preoperative motor levels, C5, C6, C7. I mean, it couldn't be more, it's only 3 patients, but it couldn't be more disparate than that. You know, different transfers as well. So, you know, I mean, you can't really, no one can draw conclusions yet to say that, you know, things like age is an issue, or time to surgery is an issue. When you look at the preoperative EMG, I don't think it gives you really any information that you don't already have. In the donor nerves and in the recipient nerves, you've got some proportion that have fibrillations. And in terms of recruitment, in the donor nerve, you've got normal or slightly reduced recruitment, which really you could have predicted because you examined the patient and their donor nerve's muscle was working. And that's how you know you can do a nerve transfer, is if you examine the patient, and you don't necessarily need the EMG to, it's sort of reassuring to see it, but you knew already. And same with the recipient, discrete or no recruitment, the muscle's not working. You knew that already because you examined the patient. Here's a patient, again, you know, operated on 36 months after injury. He's now 6 years post-op. He's had bilateral supinated AIN, so grasp and pinch that we wouldn't have been able to otherwise reconstruct, and he's got bilateral brachioradialis to ECRB tendon transfers, and he's also had a right deltoid triceps. And what he's doing in the first video is extending and flexing his wrist so that you're not thinking to yourself, it's just his wrist extension, it's just his tenodesis that's allowing him to hold on to that bar. It's not, it's the power in his grasp and pinch. And he's not as strong on the left as he is on the right. There he is picking up a fairly heavy, fairly big block. So he would have had no ability to do that pre-nerve transfer. So it was worth doing in him. And he's actually got some registerable grasp and pinch strength that I've listed there. So sometimes it can be hard. You know, patients have got something they're using, but you can't pick it up on the dynamometer. My tentative conclusions, given that this is a tiny series, delayed more than 18 months post-spinal cord injury nerve transfers provide a surgical option for upper limb reanimation in patients whose recipient nerve innervated muscles stimulated pre-surgery with SES. I mean, maybe it works in patients who they don't stimulate, but we haven't done any of them, so I don't have a control group for you there. All muscles that stimulated pre-op with SES stimulated intraoperatively, so it correlates exactly. You cannot draw conclusions between age and time since injury and strength outcomes. We don't have the information yet. The results are mixed in elbow extension. Delayed spin does seem most reliable. And if you're going to do a delayed transfer to AIN, I mean, do it if you've got no other option for grasp and pinch. But if you do have brachioradialis, you might think about putting brachioradialis onto the thumb as a tendon transfer and doing the supinated AIN to try and give them grasp and pinch and sort of guarantee that you're going to get pinch, because if it's going to fail, it's going to fail in FPL.